I'm calling, sir, while you start the program, okay?
Okay.
Good evening, all. Dr. Rekha Rajendra Kumar from Bangalore. Greetings from Bangalore to all of you, neighboring state.
Thank you. Thank you.
Sarvata Madam, Namaste. Chakravarti Sir, Revati Madam, all seniors. We have met in the conferences, but I'm sure that you will not remember me. So I thought I'll give my introduction briefly here.
So we are live now.
We remember you. Thank you, Madam.
Nilesh, I think you can start the program.
So good evening to all respected faculty members and delegates who are present over here. I am Nilesh Darji from Corona Remedies. Welcomes you all in this 181st edition of Happy Learning Masterclass webinar series in association with Coimbatore, Dindigul, Erode, Dharmapuri, Kanchipuram, Karur, Krishnanagari, and Madurai. So the theme for today's webinar is mixed bag. And convener for today's webinar is Dr. Asha Jain ma'am. Let me introduce madam. Dr. Asha Jain madam has very vast 32 years of experience, and madam has Foxy recognized ultrasound and colposcopy training center. Madam is currently director SMSA Hospital Raipur, medical director Cancer Prevention and Relief Society. Madam is elected member of Chhattisgarh Medical Counseling, and madam's fields of interest are saving the uterus, fetal medicine, ops and gyn ultrasound, critical care, preventive oncology, and colposcopy. So I welcome you, madam. And as per the traditional course, we would start our webinar with light lamping session. Thank you so much for your patience. Now I hand over the session to Dr. Asha Jain. So over to you, madam.
Thanks a lot. Thank you, Nilesh, for that kind introduction. Namaskaram to all the respected faculty who are present here. Namaskar to all the delegates who have logged in. And Dr. MC Patel sir has joined us now. As you all know, this is the 181st episode, which was dreamt of by Dr. MC Patel sir. He started the whole program. And this is the fourth round. And in this fourth round, he has started taking a reverse panel. He has joined us now, and I request sir to kindly take over and welcome all the guests officially. Welcome, sir.
Hello, MC sir.
Asha madam, you are muted.
Okay. So, while sir unmutes himself, I would like to introduce my coordinators for this evening. We have Dr. B. Kalpana ma'am, and we also have Rekha Rajendra Kumar ma'am. Dr. B. Kalpana is no stranger to this series. She was in this series for long as a coordinator till she became the chairperson Infertility Committee Foxy. Congratulations, ma'am. And we also have Dr. Rekha Rajendra Kumar ma'am, who's been with us for long, and she is the president-elect of Bangalore Society. She's also a coordinator for a lot of time, and she will be going for chairpersonship in the next session. So while Sir joins in, I would request Dr. Kalpana to say a few words of welcome.
Thank you, Dr. Asha. Good evening, everyone. Actually, I'm really happy to be a part of this webinar series, that 281st series. Welcome, MC sir. Your welcome address first.
Thank
Dr.
you.
Kalpana, you finish yours now. It's a
Oh,
couple
yes,
of
you
minutes,
finish,
we'll
then I
take
will
them.
take. No issue. There was some connectivity issue. No issue.
Actually, this platform is not new to me. I've been associated with this platform for years together, working hard in this platform. Thanks to MP sir for the guidance. And this series he has been conducting on every Tuesday. Many a times it is on Tuesday and Thursdays. The organizing chairperson is MC Patel sir, who is a medical legal expert, ready to help each and every gynecologist. Even he gives his this visiting card to keep it under the pillow so that every gynecologist can have very good sleep. So we have wonderful coordinators, Asha Jain ma'am and Rekha Rajendra Kumar. The topic of discussion today is high-risk obstetrics, where we are going to discuss about medical legal issues in high-risk obstetrics. Also, it is my honor to have our own leaders, leaders of Tamil Nadu, Amala Devi ma'am, President Dindakal Society, Chakravarti sir, President Kanjipuram Society, Revati Janakiram ma'am, past President TNF Fuji, and also speakers Ambigai Meena ma'am from Madurai, senior consultant, Senturu Ramachandran madam, Parvada Vardini madam, Dr. Amirdavalli as chairpersons, and we have long list of panelists who are going to bombard the questions towards MC sir. We have president secretaries from various societies, Coimbatore, Manohmani, Madam Selvarani from Dindakal Society, Asha Rao ma'am, future vice president, Umayal from Kanjipuram Society, Dilshat ma'am from our own city, Rekha Rajesh, president of Huzur, and our own president secretaries, Mahalakshmi ma'am, Padma ma'am, and also many other senior consultants who are going to raise questions about medical legal issue. Hope this would be a successful webinar. Thank you so much.
Thank you, Dr. Kalpana. Requesting MC Patel sir. Sir, can you hear me?
Yes, 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 I am here.
Over to you now.
Yes. So it gives me immense pleasure to welcome you all for 181st episode of this Happy Learning Masterclass web series. And I welcome all the societies who have joined this webinar: Coimbatore, Dindigul, Erode, Dharmapuri, Kanchipuram, Karur, Krishnagiri, and Madurai. I welcome Dr. Revati Janakiraman madam. She has kindly consented to be chief guest to bless us for this webinar. Of course, she is always with us in any of our academic activity. So welcome, madam. I also welcome two guests of honor, Dr. Amala Devi madam from Dindigul and Dr. Chakravarti sir from Kanchipuram. Of course, Amala Devi madam is always with me in any of my academic activity. Welcome, madam, and thank you for sparing time. I also welcome Chakravarti sir. He is also with me to inspire me for my academic activity. So welcome, sir. I also welcome a very learned speaker for today's webinar, Dr. Ambigai Meena from Madurai. She is going to discuss very interesting topic for today's webinar, and that is sudden obstetric collapse. Because in our day-to-day practice, we may come across this type of mishap at any time. So she is going to deal with this very subject. And to chair that very session, I welcome three learned chairperson, Dr. Senthiri Ramchandran Madam from Madurai, Dr. Parvata Vardini Madam from Madurai, and Dr. Amiratha Valli Madam from Madurai. They are going to give their inputs as a chairperson as far as this topic is concerned. And then after reverse panel on high risk pregnancy, and all the learned panelists from different society of this joining society are going to bombard question. So I welcome Dr. Manonmani Madam, President Coimbatore Society. I also welcome Dr. Selvarani Jayaraman from Secretary Dindigul. I also welcome Dr. Sugandhi Kumar, past Secretary of Erode Society, Dr. Renju Arun, Assistant Professor in Erode Medical College, Asa Rao, past Chairperson, Endometriosis Committee from Coimbatore. I also welcome Dr. Umayal, Secretary, Kanchipuram Society, Dr. Dilsad Madam, ex-Director, KGHISO, Madras Medical College, Dr. Devi Lakshmi, Secretary, Karur Society, Dr. Rekha Rajesh, President, Krishnagiri, Dr. Anitha, Madam, President, Dharmapuri Society. I also welcome Dr. N.K. Mahalakshmi Madam, President, Madurai Society, Dr. Padma, Secretary, Madurai Society, and Dr. Chandrakala Maran, HOD, OBGYN, KGPG, Medical Institution, Coimbatore, and President-elect of Coimbatore Society. I also welcome Sujatha, Madam, Secretary, Krishnagiri OBGYN Society, to this learned panel. I also welcome convener Dr. Asha Jain from Raipur, past president of Raipur. She is in this series since long as a convener, and she is connecting all of you with this webinar very effectively, efficiently, and in a very different manner. I also welcome two coordinators. Of course, she was in this series since long as a coordinator. She is again with us. Whenever we have called her for any assistance, she is always with us. So thank you, Kalpana, for the same, for this webinar. And
invitation,
activity, and welcome. I also welcome Dr. Rekha Rajendra Kumar, coordinator, one more coordinator from Bengaluru, President-elect Bengaluru. She is also in this series since long as a coordinator. So I also welcome all the president and secretary of joining society and all the delegates who have joined this important webinar. So without wasting much of your time, I simply would like to say, in era of COVID-19, when this physical meetings were not possible, I started with series these three people, and now in this 2024 with this 181 episode of Happy Learning Masterclass, we have 7,000 plus member family as far as Happy Learning Masterclass web series is concerned. And we usually discuss focus topic. And with this fourth round, 3 round, we have already completed with all the Society of Proxy. And in fourth round, we have little change in our module. Reverse panel, panelists will ask question, and being a moderator, I will be answering the question. And if at all any question from delegate, they may put in chat box. At the end of panel, we may entertain those questions also. So welcoming you all again. Thank you. Thank you very much.
Thank you, sir. Thank you very much. I request everyone, if you would put on your cameras for a minute, your video on, so we would take a group photo and then we will start the scientific session. Requesting everyone, please put on your photographs. Okay, there's one person who has still not done it. Thank you. Thank you very much. With this, we end the inaugural ceremony, and I would like to, we start the inaugural ceremony, and I request Nilesh, please share the CVs. So it's a great honor to introduce Dr. Revati Janaki Raman ma'am, who is the former director of IOG Chennai. She was VP Foxy South Zone in 2016 and President TN Fog 2023. A very senior but extremely humble, hardworking teacher who is inspiring everyone around her and a good musician as well. She's also the founder, secretary, and past president of Madurai Society. We've all heard her Veena recital in Dr. Priya's programs. She's also the founder, president of Madurai Menopause Society, and a lot of other things, author, chapters. She also has a Pride of Foxy Award in November 2019 at Mumbai. So welcoming you, ma'am, to this webinar. We are really honored to have you with us, and we would like to really hear some words of blessings from you.
Thank you. Thank you very much, Dr. Asha. Good evening, dear friends. Thank you, Dr. N.C. Patel, sir, and Asha, for your kind invite. I'm sure, except Dr. N.C. Patel, no one else can take up such mammoth task of conducting 180 plus webinars, all very, very informative as well as interesting ones. Also, he connects all Foxy societies and brings out many eminent speakers too. Today, we have excellent teachers, Dr. Ambige Meena, Dr. Chandru, Dr. Parvadavadini, and my own dear best student, Dr. Amritavalli, and so many people. Sudden maternal collapse and legal issues in high-risk pregnancy are the topics chosen today. Really, they are the topics in need of the hour. Everyone have to know about it. Today, we have a galaxy of panelists who are going to bombard Patel sir, who is the authority in medico-legal issues, we know. I'm sure all participants will benefit a lot, and we are all very eager to listen to you, sir. Once again, thank you, and my sincere and best wishes to you, sir, for your success in forthcoming president election, Foxy. Our Tamil Nadu support is always there for you. Thank you very much, sir.
Obliged. Thank you, madam. Of course, you are always with me in any of my academic activity. You have inspired me a lot in past also for any of my activities. So thank you, and thank you for sparing time to bless me.
Thank you, sir.
Thank you. Please share the CVs. Requesting Dr. Rekha ma'am to introduce Amala Devi ma'am.
Yeah, thank you, Dr. Asha madam, for the kind opportunity. It is my esteemed honor and pleasure to introduce none other than the senior most gynecologist madam, president of Dindigul Society, Dr. Amala Devi madam. Madam has a very, very rich CV. I'll just take few excerpts from that. Madam has a special services where she has done more than 50,000 cases of laparoscopic tubal ligations in the district of Dindigul, Madurai and Periyankulam districts. Madam has lots of awards like Best Social Worker Award, IMA Meritorious Award, State President Appreciation Award, and lots of awards to her credit. Madam is also a member of many, many prestigious institutions where she has decorated the very high topmost post in all the committees and the institutions. Her field of interest is a very noble task of women empowerment, and she is too keen on the upgrading of the health of adolescents. Over to you, Amala Devi madam. We are extremely honored by your mere presence. We would like to hear from you. We are happy to have you, and we are very sure that you will enrich our knowledge.
Thank you. Good evening to everybody, and my special thanks to Dr. M.C. Patel. And there is a saying that behind every woman's victory, there would be a man. But I think for all the Foxysian women obstetricians, M.C. Patel sir is behind us to tackle our problems and for our victory also. So this all over the world, the subject of women's health is gaining more importance, and it's the top of priority of healthcare professionals, policymakers, and educators alike. So in this program, on the 181st seminar, who was arranged by MC Patel sir throughout from the COVID period, it is running without any break in that. So we thank him and all the coordinators, the convener, Dr. Asha Jain, chairpersons, organizers, the moderators, the speakers, and it is very glad to tell that always when he makes a seminar, he does it from the south also. He includes all the south women, which didn't happen in the previous years. And Coimbatore, Dindikal, Karur, Kanjipuram, and Krishnagiri and Madurai, all these districts were joined together, and we feel very proud, and we feel prestigious also to be a part of this program. And my congratulations, advance congratulations for MC Patel sir for his forthcoming this election. Surely I pray God that he will become the president of Oxy so that we can benefit more from him. And thanks to one again all the South Society presidents and the secretaries and my dear friend Dr. Revati and Dr. Chakravarti and Kalpana, everybody who had joined here to run the show in a very great manner. Thank you.
Thank you. Thank you very much, madam. Obliged. With your presence only, I am inspired in a few of them are academic activity in past also. So thank you for sparing time.
Thank you, ma'am. Now I request Dr. Kalpana ma'am to please introduce Chakravarti sir. Dr. Kalpana, you're muted.
Sorry, Chakravarti sir doesn't need any introduction because he has been running various conferences in the past and planning a few great conferences in the near future also. President of Vibrant Society, Kanjipuram Society, and he has done his undergraduation, post-graduation at Madras Medical College. He was in service for 33 years, worked as Deputy Superintendent, Dean in charge, Chengalpattu Medical College, various other medical colleges, President of Obstetrics at Oxy in 2000. He has also received Lifetime Achievement Award by IMA in 2017, Best Doctor Award from Tamil Nadu government in 2018. Your words of wisdom, sir. You are muted, sir. Please unmute yourself, sir.
Now?
Yes, yes.
Good evening. I thank Dr. Patel sir for giving me an opportunity to be along with you, the learned speakers and very probable discussions. And it's really an honor for me to be a guest of honor in this program. Sir has been doing for the past 181 so successfully, a man with vision and a man who can talk anytime about the forensic aspects of obstetric anatomy, which is a day-to-day, almost terror for all the obstetricians. Sir, I pray and wish you that you get the president next year and wish you all the good luck. Thank you for giving me the opportunity. Thank you, sir.
Thank you
all.
Thank you. Thank you, sir. You are always with me, and
Yes,
I still cherish my sweet memory during my visit to Kanchipuram in one of the conferences, and you had taken personal care as far as warm welcome and hospitality is concerned. So you are good host also. So thank you, sir, for the same. And thank you for sparing time to bless us.
Please, sir. Please, sir. It's a pleasure for me, sir.
Yes.
Thank you, sir. And before everyone disperses, I would like to request everybody's blessing for my candidature for Food, Drug and Medico-Surgical Equipment Committee. So please help me from your societies. And with this, sir, we would end this session. The
yes.
inaugural session will be closing here.
Yes.
Thank you, Corona Remedies. Thank you, respected Chief Guest Revati ma'am, guests of honor, Dr. Amla Devi ma'am and Dr. Chakravarti sir, and all the faculty present here. Now we go forward to the scientific session. May I have the chairperson CV, please? Over to you, Dr. Rekha. You're muted, ma'am.
Yeah, I know. Thank you, Dr. Asha. As you said, we have finished the inaugural ceremony and we are into the academic session now. The first talk is on sudden obstetric collapse. I request the chairpersons, the first Dr. Senthiru Ramachandran Madam, to chair the session. Madam is a UG and PG teaching faculty in the Department of OBG, Madurai Medical College for more than 2 decades. University first rank in Diploma in Obstetrics Gynecology as well as Masters. Winner of Sir Dr. A.L. Mudaliar Award. Madam was the treasurer of Madurai Medical College for 2 years, organizing secretary of the same medical, Obstetrics Gynec Society, secretary of Madurai Society, vice president, and she has presented a lot of papers. Madam was also the president of Madurai Menopause Society from 22 to 23 and recipient of various awards. Welcome, Dr. Senthiru, Madam. We request you to chair the session of this first talk. Can I have the CV of second chair? Yeah. Dr. Parvatavartini, Madam, Senior Madam, Professor of Obstetrics Gynecology, again from another same noble institute and a highly esteemed institute, that is Madurai Medical College, past Secretary of Madurai OBG Society, Organizing Secretary of Yuva Foxy in Madurai, Executive Member of Madurai OBG Society and faculty in many of the national conferences of Foxy. She's a senior consultant in Madurai. Thank you, Parvatavartini, Madam, and please chair this session. Another chairperson, esteemed Dr. R. Amirthavalli, Madam. She's an MBBS from Madurai Medical College, DGO in the Institute of Obstetrics Gynecology, DNB in Southern Railway Headquarters Hospital, Chennai, and at present working at Divisional Medical Officer in Madurai Divisional Hospital, Southern Railway from past almost 10 years. Again, I request Madam Dr. Amirthavalli to chair the session. I request the first chairperson to introduce the speaker, second chairperson Parvatavartini Madam to describe little bit and give introduction about the sudden obstetric collapse topic, and Dr. Amirthavalli to conclude with her important comments and closing session on the same topic. Thank you. Over to chairpersons to take the proceedings forward. Thank you again.
A warm good evening to you all. At the outset, I thank Dr. MC Patel sir, Dr. Asha, Dr. Kalpana and Dr. Rekha for this kind invite. This is the 181st CME of the Happy Learning Masterclass webinar series, and the topic is sudden obstetric collapse. We all know about the maternal and fetal risks associated with pregnancy, delivery, and also in the immediate postpartum period. Irrespective of the cause, the outcome of obstetric collapse is dependent largely upon the initial management of the patient, which should be within the first few minutes. That is very crucial. And this sudden obstetric collapse may be due to obstetrical as well as non-obstetrical causes. Now I invite Dr. Ambigai Meena to deliver the talk. Dr. Ambigai CV, please. Dr. Ambigai Meena is the former professor, Department of Obstetrics and Gynecology, Madurai Medical College, Madurai. She is MD Shri Meenakshi Hospital, Center for Laparoscopy, Obstetric and Gynec and Infertility. She was Secretary MOX 2011 to 13, Vice President MOX 2009 and 19 to 20, Organizing Secretary of Yuva Foxy 2012. She was awarded with the Best Doctor Award from MOX, Best Doctor Award from Madurai Medical College, and Fox Excellence Awards 2023. Over to Ambigai Meena. Ambigai.
Yeah, she is unmuted.
Parvati ma'am, if you would like to say a few words, please.
Yeah. Good evening, everybody. I thank Dr. MC Patel, Dr. Asha Jain, other chairpersons and chief guests, everybody, including Dr. Kalpana, for this to be a part of this nice CME. Today's topic is sudden maternal collapse. all the obstetricians in their practice are doing their cervix definitely should have come across this nightmare situation, and all of us we would have experienced severe stress, and we will be in a perplexed condition when we see a patient suddenly collapsing during pregnancy, during delivery, and immediately after delivery. So how to, when sometimes we come across certain risk factors for this condition, when we anticipate, when we know about the risk factor, we can anticipate, we can carefully deal the patient. Sometimes without any known risk factors, due to non-obstetrical causes like anesthesia or some other thing, the patient suddenly collapses while giving anesthesia, or she doesn't recover after being delivered by cesarean section. So many times we are so stressful and we don't know how to manage. As Dr. Chandru already told, the immediate resuscitation within few minutes would only save the patient. So the obstetrician should be trained in resuscitative measures, also immediately giving CPR, to give this laryngoscope, and then operating laryngoscope, then connecting to high flow oxygen. All these things, the obstetrician should also be very well trained in immediate resuscitation of the patient. That would be helpful before the arrival of the trained anesthetist and other supportive people who can come and help us. We should not waste the immediate time, the crucial time in resuscitating the patient. Now I call upon Dr. Ambige Meena to deliver her lecture.
My slides, is it visible?
Yes, ma'am.
Yes, yes.
Make it full screen.
Okay.
It is seen, ma'am. You can
Yeah,
go.
1 minute. Good evening, everyone. And thank you, Dr. MCP, for giving me a chance to be part of this 181 webinar. Really, it is a mammoth task to continue, whether it is raining or sunny day. The webinars are going on continue. You are conducting the webinars without any break. Really, it is a commendable work. And I wish to thank all the chairpersons for their nice introduction, and also all the dignitaries who were the chief guest and the guest of honor and the conveners, and all the society president and secretary of all the societies. So as being an obstetrician, especially when you are working in a tertiary care center or even in your private practice, you might be seeing a lot of cases of sudden obstetric collapse or sudden maternal collapse. As Dr. Parvati said, it is really when a patient collapses in front of you, a pregnant woman, really it is a very stressful thing for you. You have to be very strong to resuscitate the patient and go on further. So sudden maternal collapse is not only a tragedy and stress for the patient and the family, and also for the obstetrician. The sudden maternal collapse can cause, even in 15th century, all of you know about this triple obstetric tragedy, the death of Princess Charlotte, her stillborn prince, and a treating obstetrician Richard Croft, who committed suicide after the death of the mother and the baby. And in our own Tamil Nadu state, you may be remembering Dr. Sethu Lakshmi, whose patient died during a cesarean section for hypertension, and the mother and baby died. After some months, she was hacked to death by the husband of the patient. And recently, we all remember Dr. Archana Sharma from Rajasthan, a patient who died during a cesarean section. And she was, FIR was filed as on murder, and she committed suicide. So it is not only a stress for the mother and the it is not only a stress for the mother and the family, it is a stress for the obstetrician also. So sudden maternal collapse is an acute event involving the cardiorespiratory system and or brain, causing the reduced or absent conscious level at any point during pregnancy and up to 6 weeks postpartum. As collapse is not a reported event, the true incidence is difficult to estimate, but it could be as high as 6 per 1,000 births. However, where death has occurred, poor resuscitation has been a recurring theme, represents an acute illness with multiple etiologies. So what are the commonest? This collapse can occur even in the first trimester, second trimester, third trimester, intrapartum and postpartum, and late postpartum also. When you see the causes of the maternal collapse, it is starting from the head. It is eclampsia, intracranial hemorrhage, and due to anaphylaxis, there may be airway obstruction and amniotic fluid embolism, and drugs, usually with the spinal drugs or even a GA drugs can cause anaphylaxis to the patient, and illicit drugs, that is less in our country, and aortic dissection, and cardiac causes arrhythmias, myocardial infarction, cardiomyopathy, because these are the conditions which occur suddenly. A patient with heart disease become pregnant, we already know about that. Metabolic causes hypoglycemia. Now increasing incidence of GDM, and many patients who are diabetic becoming pregnant, hypoglycemia can also cause maternal collapse. Recently, I had in one of the nearby medical college, a patient was brought from the home in a comatose stage. It was a case of hypoglycemia. In spite of all the resuscitation, she was put on ventilator, but because of continuous electrolyte imbalance and all that, the patient died on the 7th day. So the hypoglycemia also has to be considered when you are seeing a patient who is brought in a collapsed condition. And hemorrhage, it is the most commonest cause in our practice, which causes maternal collapse. Even in the first trimester, it could be an ectopic pregnancy or ruptured ovarian cyst or a corpus luteum cyst, and in the second trimester abruption, and in the second and third trimester abruption, placenta previa. The third trimester in intrapartum, it could be a ruptured uterus. Apart from the ruptured uterus and all these obstetric conditions, some other conditions also, internal hemorrhage can occur, like splenic rupture, hepatic vein rupture. All these conditions without any obstetric indication, there may be internal hemorrhage and the patient may collapse. And the last and least is the sepsis. So hemorrhage, when you take the hemorrhage, this is the most common cause of maternal collapse and was responsible for 1.7 maternal deaths in the last triennium. Types of hemorrhages, it could be a revealed hemorrhage or concealed hemorrhage. Revealed hemorrhage in the case of placenta previa and revealed abruption, and also in the case of ruptured uterus, and in the case of postpartum PPH, either atonic or traumatic PPH. In all these conditions, the hemorrhage is received. Concealed hemorrhages in the case of concealed abruptio placenta, or in the case of post-cesarean intrapartum bleeding, intra-abdominal bleeding. In these cases, it could be a concealed. Causes of revealed hemorrhage is postpartum hemorrhage, major antepartum hemorrhage like placenta accreta previa and placental abruption, uterine rupture, and ectopic pregnancy. Causes of concealed hemorrhage, placental abruption, splenic artery rupture, and hepatic rupture. And non-hemorrhagic causes is sepsis, eclampsia, acute uterine inversion, amniotic fluid embolism, pulmonary thromboembolism, air embolism, and Mendelssohn syndrome. These are the non-hemorrhagic causes. And non-obstetric causes, neurological causes like intracranial hemorrhage, epilepsy, it is a post-ictal state, the patient may collapse, and subarachnoid hemorrhage, cerebral venous thrombosis can occur. Mostly it occurs in the postpartum period, so CVT. Sometimes it occurs in the antenatal period also. Cardiac causes, myocardial infarction, cardiac arrhythmias, ineffective endocarditis, and cardiomyopathy. Pulmonary is thromboembolism. It could be either amniotic fluid embolism or the thromboembolism. And metabolic is the hypoglycemic. So whenever you see a patient, pregnant women with collapse, you have to rule out all the causes. So among these, we are dividing the reversible causes, etiologies 4H and 4Ts. Reversible cause 4H is, one is hypovolemia. This is bleeding, either concealed hemorrhage or revealed hemorrhage, or due to relative hypovolemia of the dense spinal block or septic or neurogenic shock. Hypoxia in pregnant patients can become hypoxic more quickly. Cardiac events can occur. Peripartum cardiomyopathy, myocardial infarction, aortic dissection, large vessel aneurysm can cause hypoxia. hypo and hypernatremia and other electrolyte disturbances. This mainly occur in the first trimester when the patient is having severe hyperemesis and not given proper treatment. Recently, I saw one patient. She was having severe hyperemesis and she was restless and she is aggressive. She is not even keeping the IV lines. When I asked them to get admitted, she told it is due to some bad spirit, and they went to a sorceress for the treatment of the patient was with a bad spirit. So these are the our myths and our ignorance causes sometimes maternal death. Hypothermia, it is more likely it is in our country. Reversible causes, the 4 T's are thromboembolism, amniotic fluid embolus, pulmonary embolus, air embolus, and myocardial infarction. Toxicity, local anesthetics, magnesium, and other drugs. Any drug can cause anaphylactic reaction, like even a progesterone injection can cause a neurogenic shock, or even our iron sucrose sometimes, even though we are thinking it is not causing side effects are little less, sometimes these also can cause anaphylactic test reaction or toxicity. And tension pneumothorax, that is following trauma, suicide attempt, tamponade following trauma, and suicide attempt, cardiac tamponade can occur. Because in a patient, in a pregnant patients become collapsed or went for shock. It is, there are a lot of physiological changes which happen during pregnancy. It has impacts on the resuscitation of the mother. One is the aortic compression, also known as the supine hypotension. It progressively increases from 20 to may reduce the cardiac output by up to 40%. Always Susel. So whenever a patient is collapsed, brought to you, you should put her in a 50-degree tilt position. And all the vascular changes, increased blood volume and breathing, the lungs are compressed, pushed by the pregnant uterus, and the increased tachycardia and increased respiratory rate, all these can cause difficulty in resuscitation of the patients. The pregnant uterus comprises of external cardiac massage up to 90%. Also, it compromises the chest ventilation, so hypoxia occurs more rapidly. And if you want to give a proper resuscitation, proper CPR, then you have to empty the uterus at the 5th minute after the cardiac arrest, which has occurred in front of your eyes. Blood volume is increased by up to 50%, but mother may tolerate blood volume up to 30%. So it may misguide you. You may think the blood loss is less and you may not react properly. Increased risk of stomach regurgitation, aspiration occurs in a pregnant woman. So whenever a patient is collapsed and if the patient is breathing, first put her in the recovery position. For that you have to, this is the recovery position. The patient is turned to the left and her hand her head tilted to keep the airway open, and left hand side for someone heavily pregnant. If injury to the left side prevents this, then you can perform the right side, and you have to keep a wedge. If you are not able to put the patient in this position, you can put a cardiac wedge, or you can put a folded bed sheet, or you can ask one of your assistant keep their knee under the right hip. The hand supports the head and mouth is towards the ground. This is the proper recovery position for a patient who is collapsed, for a pregnant woman who is having a collapse. Resuscitation, actually the management of the collapsed pregnant woman should follow the standard ABCD approach to resuscitation of an adult. In the management of a pregnant woman, the sequence should be as follows. First, you see check the signs of life. If the patient is unresponsive and not breathing, immediately you have to call for the resuscitation team. In Western countries and all, they will have a code C, code blue, like that. They will have that. Once you tell announce it, code C or code blue, immediately the resuscitation team will come to the ER, or if the patient is in the labor room, they will immediately come with all the things for to resuscitate the mother. I think still we have to form such a resuscitation team in our institutions also. And put the patient in the left lateral uterine displacement and start CPR. The CPR should be in the middle of the chest with both the hands, and it should be 6 to 7 centimeter depth we have to press, and the number of compressions are 30 and number of breathing is 2. So in 1 minute, at least 100 compressions and 5 to 6 respirations should be there. and attach the fibrillator. In the meantime, you have to give IV access, high flow oxygen, continuous chest compression after intubation, treat the cause. If you have found any cause, bleeding or something, you have to treat it. If it is due, and adrenaline should be given 1 milligram IV every 3 to 5 minutes. If indicated, you have to consider other drugs, amlodipine, magnesium, and and all these drugs should be continued. And shock, if there is a ventricular fibrillation and pulseless VT, then you can deliver the shock and resume the CPR for 2 minutes. If there is a non-shockable rhythm, then you have to resume CPR for 2 more minutes. If the patient return to circulation, then you continue resuscitation and put the patient, if necessary, for ventilator. In the meantime, you have to assess the fetal well-being also. If the patient does not respond to a CPR and there is no recovery of the systemic circulation and all that, you have to do a perimortem cesarean section in the 5th minute. So the primary survey uncovers immediate life-threatening problems. You have to do, find out, identify the life problems and deal with these problems as they are identified. Airway with cervical spine control, breathing and ventilation, circulation volume replacement, hemorrhage control, disability or neurological status, exposure in environment, adequately expose the patient to promote, help you to resuscitate the patient. Assess the fetal well-being and viability when the CPR is successful. So this is again the algorithm for how to resuscitate a pregnant patient who has collapsed. And amniotic and various causes which are causing the sudden maternal collapses. One is amniotic fluid embolism. It causes biphasic response. It can occur in any patient who precipitate labor, tumultuous contractions, and hydramnios or induction of labor. In all these patients, it can happen. First phase is pulmonary vasospasm that leads to pulmonary hypertension that leads to right aortic dysfunction. Second phase is left ventricular function, pulmonary edema, ARDS, and DIC. If you revive the patient who has gone for amniotic fluid embolism, which is only exclusion diagnosis, once you rule out all other causes, then the probable cause could be the amniotic fluid embolism. Revive the patient may go for neurological deficit and also DIC. And how it causes this ARDS is exposure to amniotic fluid or fetal antigen causes immunological release of the mediators. Also, it can cause mechanical obstruction and it causes complement system activation and coagulation system activation. The immunological release of mediators, complement system activation, everything lead to cardiopulmonary effects, that is acute pulmonary hypertension, hypoxia, and right ventricular failure. This coagulation system activation causes consumptive coagulopathy, cardiopulmonary collapse, and finally death. The left ventricular failure and also it causes AFP patients can go for coma, seizures, residual deficits, acute respiratory distress syndrome, other organ dysfunction. All these can cause at the end cardiopulmonary collapse and death. So the management is intensive care monitoring. One should be aware that there is a high risk of developing ARDS, heart failure, and DNC. Supportive treatment, ventilation, inotropic support, hematological support, steroids may be useful. Potential intervention to serve the life-threatening case of AFB is inhalation of the nitric oxide for pulmonary hypertension, leading to right-sided heart failure. And if facilities are available, the patient can be put on ECMO. And another commonest cause is the sepsis, the significant cause of maternal mortality and morbidity. Standard care continues to future in the cases that result in death. Bacteremia, which can be present in the absence of pyrexia or raised white cell count, can progress rapidly to severe sepsis, septic shock, and leading to collapse. We should not think only the patient who is having fever is having sepsis. Sepsis can occur even without fever. So you have to see the other symptoms and you have to come to a conclusion. The most common organisms implicated in obstetrics are the streptococcal group, ABD, and pneumococcus, and Escherichia coli. And next is the drug toxicity overdose. The drug toxicity overdose should be considered in all cases. Illicit drug overdosage, still it is very rare to find in our hospital. The common source in obstetric practice of drug toxicity is magnesium sulfate, which was given for eclampsia and imminent eclampsia. In the presence of renal impairment, magnesium toxicity can occur. And local anesthetic agents, which are injected intravenously, when you are giving a infiltrate the perineum with a local anesthesia, or if you are giving a spinal anesthesia, that also can cause toxicity and overdose. And the feeling of inebriation, lightheadedness followed by sedation, circumoral paresthesia, twitching, convulsions can occur in severe toxicity. And signs of severe toxicity include unconsciousness with or without tonic-clonic convulsions, cardiovascular collapse, sinus bradycardia, conduction blocks, asystole, ventricular tachyarrhythmia can occur. In terms of local anesthetics, total spinal block or high spinal epidural blocker. Many of us might, after giving local anesthesia, some of the patients going for shock. So if local anesthetic toxicity is suspected, stop injecting it immediately. Lipid rescue should be used in cases of collapse secondary to local anesthetic toxicity. Intralipid 20% should be available in all maternity units. And treatment of cardiac arrest with lipid emulsion consists of an intravenous bolus injection of intralipid 20%, 1.5 ml per kg over 1 minute, 100 ml for a 70 kg woman, followed by an intravenous infusion of intralipid 20% at 0.25 ml per kg per minute, 400 ml over 20 minutes for a 70 kg woman. The bolus injection can be repeated twice at 5-minute intervals if an adequate circulation has not been restored. A further 2 boluses of 100 ml at 5-minute intervals for a 70 kg woman. After another 5 minutes, the infusion rate should be increased to 0.5 ml per kg 1 minute. If required, circulation has not been, if adequate, circulation has not been restored. CPR should be continued throughout this process until an adequate circulation has been restored, and this may take over an hour. And anaphylaxis, the common triggers are a variety of drugs, latex, animal allergens, and food. The incidence is 3 to 10 in 100,000 with a mortality rate of around 1%. Anaphylaxis is likely when all the following 3 criteria are met. Sudden onset, rapid progression of symptoms, life-threatening airway and airway obstruction, breathing and circulation problems, skin and mucosal changes, flushing, urticaria, angioedema. Exposure to a known allergen for the women supports the diagnosis, but many cases occur with no previous history. Mass tryptase levels can be useful. If anaphylactic reaction occurs in the community, the women should receive basic life support and be transferred to a hospital setting as quickly as possible, unless a suitably trained healthcare professional is present with appropriate equipment drugs, in which case definitive resuscitation treatment should be commenced. In the definitive treatment for anaphylaxis, they have an IV line, start IV fluids. The definitive treatment is injection adrenaline, 0.5 ml intramuscularly. If you are having anesthetist or some other person with you, you can go for IV. Otherwise, 0.5 ml adrenaline intramuscular is enough. This dose for intramuscular use only, we are not going to give intravenous unless adrenaline treatment can be repeated after 5 minutes if there is no effect. In experience, and it can be given intravenously as 50 microgram for bolus. Adjuvant therapy consists of chlorpheniramine maleate 10 milligram and hydrocortisone 200 milligram. Both can be given IV. And the most important cause of maternal collapse is the hemorrhage. This major obstetric hemorrhage has been estimated the incidence of 3.7 per 1,000 maternities. Causes of major obstetric hemorrhage include postpartum hemorrhage, major antepartum hemorrhage from placenta previa, accreta, placental abruption, uterine rupture, and ectopic pregnancy. Concealed accidental hemorrhage should not be forgotten, including following cesarean section, ruptured ectopic pregnancy. Other rare causes of concealed hemorrhage include splenic artery rupture and hepatic rupture. Just I want to present one case. This happened long time ago. A patient was brought in the evening to the labor ward with the pain abdomen, and her BP was 170 like that, and her FH was good. There was no tetanic contractions, or not, uterus was not tense tender, no vaginal bleeding at all. But and so that time we didn't have an ultrasound, so we cannot do an ultrasound. Just monitor FH monitoring only with a fetoscope only. And the patient was handed over. Then next day morning also that patient, but still the patient was sick. There was abdominal distension, and surgeon's opinion was obtained. One unit chief wanted to do a laparotomy. The another unit chief was it is not an obstetric condition, better not to do a laparotomy like that. But the next day night when I came for a takeover, I saw the patient just, he was lying on the left lateral position without the assistant was handing over to him. That patient was lying like that. Immediately when I went, saw she was collapsed. We could not revive her. So out of interest, we did a small incision and palpated the uterus and all that. The uterus was intact. It was a splenic rupture that was collected in the capsule and slowly oozing out, and we lost the patient. So when you are not able to come to the conclusion, nowadays we are having a MRI, you are having, and you are having ultrasound, everything. So these kind of missing the diagnosis will not happen nowadays. But anyway, you have to keep in mind, other than obstetric causes, there may be intra-abdominal bleeding due to some other other problems also. And whenever you are seeing a patient with a shock, you must calculate the shock index. It is very simple thing, and it will help in the periphery and the individual hospitals run by individual doctors, and also for the institution also. It is simple, just heart rate divided by the systolic blood pressure. The normal value in a pregnant woman is 0.7 to 0.9. Shock refers to a reduction in the tissue perfusion, clinically identified the following symptoms: lactic acidosis, altered mental status, oliguria, and tachycardia. And the shock index has an inverse linear relationship with the LV stroke volume. If there is an increase in the shock index, that shows the left ventricular stroke volume is less. So that means that the heart rate is high and the systolic BP is low. So the shock index will go more than 9, 1, 2, like that, depending upon the heart rate and the systolic blood pressure. So in shock index, if it is more than 0.9, it shows the patient needs urgent resuscitation, find out the cause, correct the cause, and revive the patient. And it is associated with increased maternal mortality and morbidity. If the shock index is more than 1, it increases, it shows the need for blood transfusion. And when you are seeing a patient with a hemorrhage, you can use the rule of 30. That systolic pressure falls by 30 millimeters of mercury. For example, most of our patients, our systolic blood pressure will be 101, 110, like that only. It is very rare to see a patient with 120 systolic pressure. So if there is 80, something like that, that shows the patient is having bleeding or some other cause for the fall of BP. Pulse increased by 30 beats per minute. Hemoglobin falls by 30%. That is about 3 grams decrease in the from the original hemoglobin. Hematocrits, if it falls by 30%. Estimated blood loss is 30% of the normal. That is in a normal adult, 70 ml per kg blood loss, and in a pregnant woman, 100 ml per kg blood loss during pregnancy is 30 ml, 30% of the loss. And the aim of in these cases, when you are having hemorrhagic patients, our aim of blood transfusion is maintain the PTTT and APTT less than 1.5 mean cutoff. Platelet count should be more than 50 into 10 to the power of 9 per liter. Fibrinogen level should be more than 1 gram per liter. Ionized calcium should be 1.13 millimole per liter. When you are going for a massive blood transfusion, then you have to, massive transfusion protocol, you have to give the calcium levels goes, you have to give calcium gluconate injection. Preferability transfuse ABO compatible platelets, and the ratio of massive blood transfusion protocol is 2:1:1. Some of the institutions follow 1:1:1. The audience and the experts can share their experience about this. And coming to the PPH, that is most commonest cause of collapse in our country. And nowadays, PIH, eclampsia and preeclampsia taking over the PPH, because we are managing, all the institutions and all the obstetricians are managing the PPH effectively. As per FIGO, intravenous oxytocin alone is recommended as the first line of butyronic drug for the treatment of PPH. If intravenous oxytocin is unavailable, or if the bleeding does not respond to oxytocin, the use of intramuscular ergometrin can be given, or prostaglandin or sublingual misoprostol 800 milligram is recommended. And misoprostol dose need not be repeated. The use of isotonic crystalloid is recommended instead of colloids to maintain the volume. And early use of intravenous tranexamic acid as soon as PPH is diagnosed, but within 3 hours of birth, in addition to standard care, is recommended for women with clinically diagnosed PPH following vaginal birth or cesarean delivery. But most of the time, when we expect more bleeding, cases like prolonged labor or sepsis or a case of multiple pregnancy, polyamnios, in all these cases, we are using prophylactically tranexamic acid. In most of the places we are using it. I think it is acceptable only. Not waiting wait till 3 hours. Administration of 1 gram of tranexamic acid intravenously at 1 ml per minute. That is over 10 minutes with the second dose of 1 gram intravenously. Bleeding continues after 30 minutes or bleeding restarts with 24 hours of completing the first doses recommended by the FIGO. It reduces the maternal death due to bleeding through scaling of the tranexamic acid for PPH treatment would have a positive impact on health equity and improve outcomes among disadvantaged women, especially in the low and middle income countries. And uterine massage is recommended for treatment of PPH. Use of bimanual uterine compression is also recommended. If the patient does not respond to the uterotonics and all that, you can go for uterine balloon tamponade, which is recommended. Nowadays, SR cannula is available, which is a very good, which gives very good results. And uterine artery embolization, it is in a setup where there is a interventional radiologist available all the 24 hours. In that case only, you can go for a uterine artery embolization. Bleeding does not stop despite treatment with uterotonics and other available conservative interventions. Surgical interventions are, you can go for a surgical interventions, that is compression sutures, uterine and stepwise uterine, stepwise ligation and hysterectomy. The priority to stop bleeding before the patient develops coagulation problems and organ damage from underperfusion should be our aim. Conservative approaches should be tried first, but rapidly moving to the surgical invasive procedures should be done depending upon the patient's condition, blood pressure, amount of bleeding, and the respiratory rate and output, everything. Hysterectomy, it can done, but it should not delay the hysterectomy. Delay the hysterectomy may cause the life of the patient, mother also. And carbetocin, nowadays we are using carbetocin. FIGO says carbetocin also can be used. Carbetocin, oxytocin, methergine, and carbetocin. If once you use a carbetocin, you cannot again go for an oxytocin because the carbetocin will block the oxytocin receptors. You go for other uterotonics like ergometrin. I don't know how many people still you are using methyl ergometrin nowadays because we are going, since we are practicing arm still in all the institutions, they are mainly using oxytocin only. And a word about the perimortem cesarean section. It is not to save the baby, it is facilitate the resuscitation. Usually when the patient collapses after 20 weeks of pregnancy, you can go for a perimortem cesarean section to do an effective CPR. If the recovery of the circulation does not occur with 4 minutes of CPR, perimortem cesarean section can be done in the resuscitation area itself. You need not shift the patient to the theater. And some of the guidelines say you need not get a consent also. I think Dr. MC Patel will give a clear idea about that. And the incision is the vertical incision. Since the patient is unconscious and the circulation is not there, vertical incision of the abdomen and classical cesarean section to be done. Closure can be done later. And clinical governance, when you are resuscitating the patient, at the same time, you have to maintain the records. You should allocate in the labor room itself, we should have an emergency directory. If possible, you should have a crash cart, which have defibrillator, everything in laryngoscope, all the difficult airway management instruments, everything should be available. And even like we are keeping a PPH tray, eclampsia tray, like that, you should have an emergency tray with all these drugs all the adrenaline, hydrocortisone, everything should be available. We should not run here and there. The patient's attendant will think we are not fully equipped. And documentation is most important. When you are resuscitating the patient, we may not be able to document everything right. So you can alert one person to put the time and write what are the drugs you are giving and everything they can write. At the meantime, you can allocate one responsible person to explain the relatives about what is happening. And poor documentation remains a problem in all aspects of medicine and can have potential medico-legal consequences. Note keeping is difficult in a resuscitation situation. So once you finish that, you should correct your case sheet, write your case sheet as soon as possible after that event. And the incident should be reported. And debriefing and training should be given. So improving the outcomes after maternal collapse, be ready. It is train stop, have emergency equipment assembled and quarantine for emergency use, have systems that assemble more stop, practice drills, be forewarned. In some of the cases, you can expect maternal collapse. That is, when you are doing a cesarean section for a placenta previa, placenta increta, percreta, like that, you can accept this patient may collapse. In that time, you should have a proper assistant. You can call a good friend to help you, and you can have anesthetist, or you can shift a patient. If you are doing a complicated cases electively, then you can have in a better setup, you can shift a patient to a hospital where everything is available. There you can do so that some of your headache and you may reduce your little headache and stress. And the patient, when she is on the slippery slope, once even after a normal delivery, you have to watch the bleeding. If you think the bleeding is more, and if the patient needs more than one uterotonic to make the uterus contract, these patients are more prone for PPH. And you have to closely watch the patient at least for 2 hours, either after a cesarean section or after a normal delivery. Put a chart and monitor the fetal bleeding, pulse rate, and BP, so that you can sleep peacefully in the night. And review and revise after each event. You have to review what you have done, what you can do to improve yourself, and how to treat a near miss case. And you can analyze and improve your equipments and your hospital and yourself also. The attitude need to be changed. Something happened. We should not blame. This is his fault or her fault, their fault, not me. We have to share our burden, share, and we have to improve ourselves, not finding fault with each other. And debriefing, that is most important. Maternal collapse can be associated with post-traumatic disorder, postnatal depression, tocophobia. And we have to tell the patient what happened, how we have saved her and all that. Family and family also. Not forget your PGs and your, in a private setup, your assistants and your staff nurses, everybody, we should be, because everybody will be upset after having a maternal collapse. If you are revived and save the patient, it's okay. If rarely, if you are not able to revive, you will feel so incompetent and you feel guilty. What else I would have done? What else I missed? Like that, everybody will worry. So you have to convince them, and you have to console them also. So important, the debriefing is an important part of holistic maternity care and should be offered by a competent professional. Conclusion, maternal collapse is rare but catastrophic event and a dire emergency. It can be caused by multiple conditions, some of which are unique to pregnancy, for example, eclampsia. The most common causes should always be considered. For example, thromboembolism, hemorrhage, maternal cardiac disease. Basic as well as advanced life support principles should be implemented, and specific interventions including uterine displacement and preparing for a perimortem cesarean section. Death and we have to accept death and disability can occur in spite of excellent care also. And it is a very big topic. And whether I have done some justice to the topic. And the take-home message is one of the biggest challenges with maternal collapse is the unpredictability and the need for constant vigilance. A logical structured approach using ABCD should be used in assessment management of a collapsed patient. CPR should be modified by securing the airway as early as possible and displacing the uterus manually. Perimortem cesarean section should be undertaken after 4 minutes of unsuccessful CPR. Obstetrician should lead a multidisciplinary team in the management of critically ill patient. All staff should have annual drills and updates. in obstetric emergency. Recently, I was talking with one of the assistant professors in a nearby medical college. They had 2 patients with maternal collapse. One patient, they tried CPR and did a perimortem cesarean section also, but the patient, they were not able to save the patient. In the second case, they done a perimortem cesarean section very quickly, and they were able to revive the patient and put the patient in the ventilator, and she became alive. Thank you.
Thank you, ma'am. Requesting the third chairperson, ma'am, Dr. Amita Valli, to please sum up.
Good evening, everybody. It was a very great session by Ambigai Meena madam. It was an eye-opening session. She dealt about the causes for sudden obstetric collapse, the ways how to resuscitate the mother and save the mother and the fetus. And she has covered almost all points. What I would like to add is that we have to anticipate sudden obstetric collapse not only in high-risk patients, but any pregnant female can land up in obstetric collapse. So we need to have an open mind and run through all the causes of sudden obstetric collapse, so that the adrenal surge within us on seeing a person who is collapsing, with our bold decision at the right time and swift action, will help us to save the mother and the fetus. As she told, what I feel is every antenatal mother should be a booked case. We have to insist on regular antenatal follow-up, and high-risk mothers should have a more frequent follow-up. A complete blood count, a urine routine, and BP checkup and sugar monitoring must be a must in every antenatal checkup. And And we need to allow for spontaneous onset of labor. If induction is essential, we need to get an informed consent for early induction. Everything should be documented. And during induction, we need to avoid hyperstimulation. And there should be a continuous fetal and maternal monitoring throughout labor. The labor room should be well equipped to manage a postpartum or antepartum hemorrhage, to resuscitate the mother or the fetus at risk. And never panic. We obstetrician have to be bold in that situation. Never panic, call for the resuscitation team, and always never feel shy to call for help. Always don't feel bad to refer to a higher institution. The meantime, before the resuscitation,
So there's been a break in ma'am's internet connection. I think we end this session here because we have a very interesting panel coming up.
Thank you all
so much, Ambigai ma'am.
Thank you, Dr. MC Patel. I wish you success in your election and want to see you as a president proxy. In Tamil, we used to say, king should be easy to approach, very simple, and he should be available for everybody to approach him easily. That one example is Dr. MC Patel. Definitely, if you become president, everybody can approach him without any hesitation. He will help everyone.
Thank you.
Thank you. Thank you, Meena madam.
Thank you.
Thank you,
One
Dr.
minute, 1 minute, Dr. Ambigai. 1 minute, madam.
Yes, ma'am.
Yes.
Dr. Ambigai has elaborately dealt with the subject, but during resuscitation, we can come across certain difficulties because of the patient's increase in breast size and uterus completely occupying the abdomen, and there is reduced movement of the diaphragm. And apart from that, there will be laryngeal edema. This poses difficulty in intubation of the patient. So we should be very careful in resuscitation of the patient. Thank you, Dr. Ambigai.
That's why you have to put a wedge and below the right hip, and you have to put her in the resuscitation. And that's why they are advising perimortem cesarean section to have a better CPR when the uterus is more than 20 weeks size.
Thank you, Dr. MBS.
And when you are opening the abdomen also, you can give a compression through the diaphragm for the heart so that it can better CPR, heart rate can come.
I think, ma'am, we need to go to the panel now because this is a never-ending half-day workshop.
Yes.
That we cannot do in 20 minutes, and we've already been at it for 50 minutes. So I think we need to proceed with the session now. Sir, may we start?
Oh, yes. Oh, yes.
So now welcome to the reverse panel on legal issues in high-risk pregnancy. Dr. MC Patel, sir, is the expert and I'm the moderator. Sir is a consultant obstetrician gynecologist and medical legal counselor. He was the vice president FOGSI 2018, has been the organizing secretary of AICOG 2017, chairperson, ethics and medical legal committee FOGSI. As Dr. Ambigai said, an extremely approachable person, down to earth and available for everyone every time. So he always says, keep my visiting card under your pillow and have a deep sleep. So I think that is what he has actually shown to the people for the last 10 years, where he has helped them through. So other than this, he is also very socially inclined. And for the last 21 years, he has been going to the Northeast to provide free treatment to the indigenous population over there. I think if I have to describe sir in one word, it would be consistency. 21 years, one place, 15 years doing the same medical legal help. And now this happy masterclass 181 is this episode. So welcome, sir. From sir, I will share an appeal which you can all have a look at. That's me. I've been introduced.
शुभं करोतु कल्याणं आरोग्यं सुखसम्पदम्.
Respected seniors and dear colleagues, serving FOGSI for years together, on this auspicious day, with folded hands and down head, I seek your guidance, blessings, and support to endorse my candidature for the post of FOGSI President, year 2026, election year 2024. Consistently working for FOGSI and trying to visit even smaller societies and to assist our common FOGSian friends in any given situation, I have tried to serve FOGSI. I assure to serve FOGSI in the same way with the same zeal and enthusiasm. पथ का अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ, आगे है बढ़ते जाना.
So with this, we start our panel. We have 14 panelists, though only 13 are seen here. And we will have 14 different situations for you, sir. I will be introducing each panelist as the name comes along. And before we actually start the panel, this is my question to you, that we all know that high risk is high risk. So is it worth discussing?
Of course, yes. Because if we go with statistic, say for example in US, 78% gynecologists faces litigation at least once in their lifetime, and 37% gynecologists should for more than 3 to 4 times in their lifetime. And if we go with Indian statistic, then medical legal cases are increasing in number constantly and steadily, and unluckily we gynecologists rank first. So total cases, we are sharing almost 29% of cases as far as obstetric and gynecological practice is concerned. followed by orthopedic surgeons, they are 22%, and then surgeon. So that way also, we should be very careful as far as our practice is concerned, and we should be vigilant because we are dealing with two lives, fetus and mother naturally, and we are vulnerable in that group as far as medical legal consequences are concerned, and we have to face litigation in so many cases. That is why it is worth discussing. And nowadays, litigations in that way also happening that advocates are very much interested to be with patient. They will offer patient that you have not to pay anything just now. We are just submitting this case against doctor. If at all we win, then some amount you will have to pay to me. Due to this type of offer, many a times patients are filing case against doctor. Otherwise, patients are not interested to file. So this is the reality in our practice, and that is why it is very much necessary to know, to discuss this type of problems.
Thank you, sir. So now we go over to Dr. Manoharmani, who is the president of Coimbatore Obstetric Gynec Society. And her hobbies are driving, reading, and music. This is her CV. Coimbatore is also Kovai Obstetric Gynec Society. She is in government service for 28 years and has guided more than 25 PG dissertations. Her field of interest is high-risk obstetrics. So over to you, Dr. Manoharmani.
Thank you for giving this wonderful opportunity to be a part of this 181 session. My question to you is, sir, why litigations are commonly related to pregnancy and labor? Which are our areas of the litigation in high-risk obstetrics?
Because this is if you go by age, so usually it is young patient. Of course, very few patients are aged. Otherwise, usually they are young patient, and usually they are book patient. Of course, few could be unbooked, but majority of book patient, and usually they come on foot in hospital. Of course, there are few emergencies. They are brought in ambulance or brought in a stretcher also, but otherwise, usually patient comes on foot, and patients and relative are not ready to accept any untoward outcome because they consider pregnancy as a physiological phenomena, even labor as a physiological phenomena, and they do not consider it pathological. So that is why, as far as our OBGYN practice is concerned, cases are much more. And we are dealing with two lives, just I mentioned prior also, mother as well as fetus. So these are the problem with us as far as this litigations part is concerned. And as far as you mentioned about area, so whenever we are dealing with any pregnancy cases and when they are with high risk, whether GDM or hypertensive disorders or any other pathology associated, then it becomes much vulnerable because many times unwanted result may come and patients or patients' relative are not ready to accept. And these are the potential situation as far as litigation is concerned.
Thank you, sir. Thank you, sir.
Yes.
Thank you, sir.
Yes.
Now we have Dr. Muruga Lakshmi, who's the past secretary of Coimbatore Society. She likes book reading and cooking. This is her CV. So she's the former medical superintendent of St. Joseph's Hospital, ICOG fellow, ICMCH, and has again an interest in infertility and high-risk obstetrics.
The CV is changed. Silver.
Yeah, so I have misplaced it. Doctors.
Yes, ma'am.
You have the question, ma'am?
Yes, ma'am.
Yeah.
Good evening, ma'am. Good evening, sir.
Yes, welcome.
Thank you to be the part of this reverse panel, sir. Sir, she's a book patient and a primey. She's conceived after 15 years of active marriage life. Conceived with ART, and she had a regular antenatal checkups, and she had a USG with every time of early pregnancy scan with NT and even target scan, interval growth scan. Every USG has normal except for polyhydramnias. At 36 weeks, sudden and intrauterine fetal death. Because her vaginal examination was not favorable and she was advised for cesarean section. Routine preoperative investigation was performed. Her blood sugar status was 432. So case was filed. Compensation was demanded for approximately 2 crores. We are not sure where things went wrong.
So, in this very case, blood sugar was never done before. And at 36 weeks of pregnancy, when it was diagnosed as IUD, and we know in GDM, an uncontrolled GDM rather, IUFD, sudden IUFD is known. In this very case, when blood sugar was not advised, was the main issue. Because as per standard guideline, from any standard textbook, any practice prevailing in nearby medical college, practice prevailing in peer group, practice suggested in index journal or in some study, blood sugar is must during pregnancy as far as antenatal profiles are concerned. And if one misses to do it, then it is all likely that she may invite litigation. So in this case also, the reason is forgetting to screen high risk factor as far as antenatal profile is concerned. So you have to strictly follow as per protocol and advise all necessary investigation. Otherwise, you may end up into this type of problem and litigation in future. Yes. Any next?
So, sir, next we have Dr. Sugandhi Kumar, ma'am. She reads books and writes poems. She sent me a small poem, sir. Ma'am, would you like to read it?
Ma'am, no, ma'am. We'll proceed with the session.
All right. Here. Ma'am, your question is on the screen.
Thank you.
Yes. Yes, Sugandhi Kumar. Welcome.
Thank you, sir, for selecting me in this panel. And my question, can you share some situations where neglecting symptoms or positive report of screening leading to litigations?
Yes. So many a time we forget because we have, when I am in active practice of medical legal, and we have faced this situation also with few of our doctors. They have never advised for blood grouping, and ultimately it turns out to be a case of Rh negative. Many a times forget to advise knuckle translucency, dual marker, triple marker, and baby had a Down syndrome. Forget to do GDM screening. Just we saw one case in this discussion only, and patient found to be having complications later. Forget to ask about some allergy to drug or to some other agents, and we miss it. So in this type of situation, many times we may invite litigation. Many a time, say for example, in sonography report, it is low amniotic fluid index, and we do not take any action. Blood pressure is, say for example, 140 by 100, 140 by 100 and 100 mm of Hg, urine albumin plus, and we take no action. So these are some situations where missing important symptoms and not properly screening the patient could be potential condition as far as litigation is concerned. Many a time, in known case of preeclampsia, patient complains about headache, and you simply prescribe tablet paracetamol and see through any fit. In a severe preeclamptic patient in labor, liver enzyme not done and HELP syndrome missed. Many a time find Saturday evening, you are in relaxing mood and there is a phone call from patient, there is decreased fetal movement, and you say that to come to the hospital tomorrow morning, and when she report next day morning, she comes with intrauterine fetal death. So these are some conditions. If you cannot neglect symptom and you cannot afford not to advise necessary investigation as far as standard protocols and guidelines are concerned.
Another question, sir. What is the importance of protocols and guidelines in case of facing litigations?
So if you have treated any patient as per standard guideline or standard protocols, say for example, FOXI guideline, AICOG, RCOG. So in this type of situation, if you have treated patient that way or a treatment given in standard textbook, it becomes a good defense in your favor. Because in court of law, always ultimate result not taken into consideration, but your efforts to save patient, to save life of patient, how you manage that very case in that very given situation, way in which any prudent gynecologist would have managed, then you could be out of problem.
Thank you, sir.
Yes.
Thank you, sir.
Yes.
Thank you, ma'am. Now we have Dr. Renju. She is the assistant professor at Road Medical College and she loves dancing. She's got the best doctor award in 2018 by Tamil Nadu government, and she is also interested in high risk obstetrics. So this is a photograph of her dance.
Very good.
Nice dress.
Sir,
over to you,
thank
Renju.
Thank you. Sir, good evening, sir. Nice to be
Yes,
part
good
of your
evening.
panel.
Welcome. Welcome.
Last time you asked me the question, sir. This time I get to ask you.
So in
Sir.
our obstetric practice also, scenario may change at any time.
Yes, sir. Yes.
Very faithful patient may
Sir.
go hostile.
Moving
Yes,
on to my
welcome.
query, sir.
Welcome, welcome.
Unbooked primary 34 weeks pregnancy with pre-IH came to the OPD. She was advised necessary investigations and treatment. Next day, abruptio placenta was noted and she came to the OPD with an intrauterine fetal death. Cesarean section was advised in view of unfavorable cervix. The relatives opted option for second opinion. They went to the surgeon. Section was done, followed by 820 pph, due to which hysterectomy was done and a notice was served. Where did the thing go wrong exactly? How are we supposed to defend such cases?
So this is real happened case, and in this very case, allegation to first gynecologist who saw that very patient at 34 weeks of pregnancy with PIH, he advised all the necessary investigation and treatment at that very first visit. As such, in few of the state, there is a customary tradition that first delivery is at maternal place. So this patient was being examined, being treated by some other gynecologist in another city, but with this gynecologist, it was very first visit. And only on very first visit, he advised all necessary investigation and treatment. But unlucky on part of patient and that gynecologist, very next day he came with abruptio and intrauterine fetal death. So allegation to that doctor was not properly managed to prevent abruptio placenta. So this is usual allegation nowadays in litigation that why you couldn't prevent it. So we have to show whatever measure we have taken to prevent this type of complication. In this very case, he had advised all necessary investigation and treatment also. So I was defending that gynecologist in this very case, and we won the case ultimately. To surgeon, because when gynecologist advise cesarean section, patient and relative opted option to bring that patient to surgeon in nearby town. and they went to surgeon, and surgeon did C-section section, and again unlucky on part of patient and surgeon, she went into atonic PPH. And in spite of all his efforts, surgeon tried his level best. He gave oxytocin, ergometrin, prostaglandin. He gave 3 units of blood also during surgery and stepwise devascularization. But in spite of all his efforts, bleeding was not getting control. And ultimately, it was decided to go for hysterectomy, and hysterectomy was done. So, allegation to this surgeon, first allegation was not tried to prevent PPH. So, in this case, this was allegation. And one more allegation was atonic PPH was not managed properly. So, if you can show by your record how you have managed that very patient in that very given situation, then it becomes a good defense in your favor. So, in court of law, I was defending this surgeon also in the same case. We could convince a court what is atonic PPH. It is beyond anybody's control. Atonic PPH may happen with any patient, irrespective of mode of delivery. And in this situation, what any prudent gynecologist or any doctor can do, if one has managed that patient way in which any doctor would have managed in that very given situation, then he should be out of problem. And we could convince court that in spite of all these efforts, oxytocin, ergometrin, prostaglandin, blood, and stepwise devascularization, to save life of patient, uterus was sacrificed. Uterus was not removed. Uterus was sacrificed. And if in one hand life of patient, and in one hand if it is uterus, then naturally uterus is to be sacrificed. And court was convinced, and judgment was in favor of both of them, gynecologist and surgeon. But we should be very careful to take utmost care of any patient in that very given situation as per standard protocols and guideline given in standard textbook. Say, for example, atonic PPH, how atonic PPH should be managed. So we should have managed that very patient as per standard medical norms. And if we can prove by our record, then it can be easy for us to face litigation. Just next.
So we have Asha Rao ma'am, sir. She was the immediate past chairperson of endometriosis committee, has a lot of things, and she's going for VP this year.
Yes, welcome.
She loves traveling and gardening, so you can see both. She also loves spending time with her grandchildren. So over to you, Asha ma'am.
Thank you, Asha Jain, for those kind words. And thank you so much, Dr. MC Patel, for inviting me here. We have been enjoying your classes for last 2 years. It's really enjoy revisiting the subject. Thank you so much. So this is Devendra Nayak versus Dr. Kalyani Dhruv, a case in 1997, Gujarat. LSC has done, bilateral uterine arteries were torn. She's Rh negative. Blood was not ready. Cross-matching also was not done. During shifting to Municipal Medical Hospital, patient expired. So notice was served. Case was filed. Allegation, not anticipated complication. Procedure or intensive care. So how do we go about it?
So in this type of situation, it was case of Rh negative. So it is expected that in case of Rh negative, at least one should send sample for cross matching, and blood should be ready. Blood should be available if at all it is required. In this case, she was unlucky gynecologist, I would say, because that very patient came to her before 4 days. She advised elective cesarean section with grouping, cross matching and keeping blood ready. But patient didn't take it seriously, relative didn't take it seriously, and they absconded from the hospital. And in emergency at 11 p.m., they had been to hospital after 4 days, and in emergency, and it was dial emergency because it was fetal distress and it was very immediate necessary to go for cesarean section. So she had no time to manage for blood also, and she took chance, and she went with cesarean section, but unlucky on part of that patient and gynecologist too. There was bilateral uterine artery tear and there was severe BPH. She was RH negative, blood was not ready, cross matching was not done. And during shifting this patient to Municipal Medical College Hospital, patient expired on the way. Post-mortem was done at Municipal Medical College Hospital. And in that very post-mortem note, person who did post-mortem examinations had a comment that it was abdominal hemorrhage due to incorrect surgical technique. It was the comment. And comment on part of court was blood was not ready, cross match was not done. And in this case, compensation of 2.35 lakhs was awarded in favor of patient party. So whenever we are dealing with this type of situation, RH negative patient, we are under obligation to send at least sample to nearby blood bank. One more point was in this very case was they submitted all the record of treatment given and efforts given on part of doctor. But in note of doctor, that is gynecologist, in her operative note, she wrote vitals were within normal limit. And at the same time, in note of anesthesiologist, it was written that vitals were compromised. So there was contradiction in note, gynecologist and note of anesthesiologist. So court took inference of that also, that this record cannot be believed when it is in contradiction. So we should be very careful whenever we offer any record to anybody. We should quickly go through that whatever we have written, it should match with our nursing chart, because in our chart we have mentioned blood pressure, say for example 180 and 120, and if it is in nursing chart it is written 120 and 80, so it will be contradiction at the same time. So we should be very careful as far as this type of record keeping is concerned. So in these two points were went against that very gynecologist. Blood was not ready and record not to be believed. But one thing I would like to discuss that also. Once patient absconded from her hospital when she advised lower segment cesarean section with all preparation of blood, in this situation, negative consent is very much required. If patient is not willing to get it admitted, get her admitted, not ready to go for cesarean section, not ready to go for blood, etc., then it becomes good defense in your favor. Because if patient doesn't follow your instruction, then it becomes contributory negligence on part of patient. So this should be managed, well recorded. But one more thing, once patient absconded, your contract with that very patient expires. Because what is legal contract? When any patient comes to you and you accept to treat her, it becomes a contract between you and patient. You are offering your services, patient pays for that, or patient promises to pay for that. But in this case, when patient absconded from hospital, patient didn't comply, then there is a breach of contract. So then after there is no contract. But in this situation, if patient would have gone to somebody other doctor's place and something wrong happened, then you are not at all responsible. But when she came again to you only in an emergency, and again you accepted to treat, then new legal contract starts that very point of time. So again, you will be considered responsible if you cannot manage that very case in a very efficient manner. So we should be very careful in this type of situation.
Thank you,
Yes.
sir.
Yes.
Thank you, sir. We have Dr. Umayal next, who's the founder, secretary, and still the secretary of Kanchipuram Society, a really dear friend, and
Yes.
does a lot of social activity, reads books, and loves cooking. But today she has lower respiratory infection. So I pulled in her son, Dr. Anit, and he
Yes,
will
welcome,
be
Anit.
taking the question.
Yes, welcome.
Thank you, sir. Thank you, sir. Thanks for inviting. Thank you, madam and sir, for the opportunity.
Yes.
So moving on to the question. So this is a case regarding Mr. Arvind Pandey and Dr. Mrs. Sulekha Saran. So the case of RH negative patient who has an whose an RH ICT was negative, antiD was also given at 32 weeks. She went into an atonic PPH during LSES and went on for the subtotal hysterectomy, and also patient died at the tertiary care hospital. So where did things go wrong in this case? So that
Again,
is my
same.
question.
Again, here also patient is RH negative. So, and again in this case also she went into atonic PPH. So a court expected that blood should have been sent for cross-matching before taking this patient for C-section, because all the utmost care were taken during her antenatal period. Say, for example, indirect womb test, NTD at 32 weeks. So this patient was taken utmost care during antenatal period. But at the time of admission, when she was RH negative and blood was not sent for cross-matching, was the point considered in this National Commission when this case was decided. But in this case, National Commission has a good comment. There is no negligence on part of doctor as far as management of this very patient is concerned. But it would have been better if she would have sent blood for cross-matching. This was the comment in this very case.
Mother has also logged in, sir. Umayal madam also. She just say hi.
Good evening, sir.
Yes, thank
Good
you.
evening. Good evening.
Thank you, Umayal.
I'm in the traveling mode, sir.
Yes.
Just thank you for logging in.
Yes, thank you.
Asha, thank you. Thank you. I've been calling.
So as far as this type of cases are concerned, it is our observation in 80% of the medical legal cases which happens with gynecologist are related to obstetric. And out of those, 80% are related to C-section complication. And out of those 80% of C-section complication, mostly these are the cases of hemorrhage. These are cases of PPH or so. So if we want to be sure of 80% litigation, out of this litigation, then we should take care of hemorrhage and blood. So if we keep blood ready, if we can tackle any obstetric hemorrhage in an efficient manner, then we could be out of problem.
Thank you, sir. So now we have Dr. Devi Lakshmi, and as you can see, she loves gardening.
Yes.
Ma'am is the secretary of Karur Obstetric Gynec Society. Over to you, Dr. Devi. You're muted, ma'am. You're muted. Please unmute yourself.
Good evening. Yes, ma'am. Sorry.
Good evening. Welcome.
Good evening, sir. Good evening, ma'am. Thank you for this wonderful opportunity. Sir, I have one question. We face so many situations like this in our practice. For placenta previa, no intercourse for placenta previa, they say you never told. Counseling on an IUGR patient about its risks, they say you never told. You had told her that in diabetes, sudden IUFD is possible, but they say you never told. So you said that everything is okay. Husband says now suddenly, how come she died of amniotic fluid embolism? How to deal with these kind of situations, sir?
So it is very simple thing. It is not just enough to communicate, say for no intercourse in placenta previa or regular checkup in non-case of GDM, but you should be in a position or you should be able to prove it that you had advised and patient didn't comply. So if you make a habit to enter into record and you can give all the protocols or profile to the patient and get it signed by patient during next visit. So it shows that you had explained everything and patient didn't comply. Because if patient doesn't comply, then it becomes contributory negligence on part of patient and it becomes a good defense in your favor. So make a habit to enter into record. It is very important thing and carry home message with this type of situation.
Thank you, sir.
Thank you, sir. Now we have Dr. Rekha Rajesh, ma'am, who's the president of Krishnagiri Society. She loves singing, dancing, and reading, but she hasn't shared it with me. She's a diploma in reproductive medicine. Over to you, Dr. Rekha.
Good evening, sir. Good evening, ma'am.
Yes,
And
welcome.
thank you for this
Welcome.
wonderful opportunity to be on this panel. I've done a few more panels with sir. And sir, each of
Yes.
your sessions are inspiring. And we have a lot
Thank
of take home. And all practicing obstetricians, I think, should at least start keeping all the, we have to archive all your talks, sir, because somewhere at some point we need it for one case or the other.
Yes.
Thank you so much for this opportunity. So my question to you is regarding this Goyal Hospital versus Kishan Gopal Shukla, where there is a patient with pregnancy with MS and MI. She's seen by the physician and the cardiologist was not involved. MTP was not advised. In failure at the 8th month, the physician advised cesarean section. During the post-op period, the death occurred in the ICU within 4 hours. The judgment said that the cardiologist was not involved. Physician's letterhead saying physician and cardiologist is a misrepresentation. MTP not advised, no surgical intervention advised in second trimester. Epidural anesthesia or spinal anesthesia should have been preferred in CCF, and they were awarded a fine of 7.8 lakhs. Sir.
So, in this type of situation, first I would like to mention that most of our friends have no habit to put stethoscope on chest. Heavy gynecology are lacking in that also. So, as soon as we come to know that there is a abnormal heart sound, naturally patient should be referred to physician or in few of the condition to cardiologist also. So here carry home message is multi-speciality approach in this type of situation. If we treat this type of patient by our own, if we do not refer patient to physician or cardiologist, then it could be allegation on part of patient party that you never inform us or you never explain us to have an opinion from physician or cardiologist. So in case of valvular heart disease or in case of any other heart problem, at least once we should refer patient to cardiologist and get her consulted by cardiologist, and we have to manage patient jointly. As far as obstetric part is concerned, we are there. But as far as her heart part is concerned, cardiologist should be with us in management of that very patient. So if we manage that way with multi-speciality approach, then if at all something goes wrong, it shows our consent that we had taken utmost care of patient to take care in that very given situation. Yes, next.
Thank you, sir. So we have Dr. Anita Thamarai, who's the president of Dharmapuri Society. This is a new society that has been made and it has been accepted by Foxy this year only.
Yes.
So her areas of interest are high-risk obstetrics and social obstetrics. Now that is a new term. And she loves cooking and gardening. And that chapati is really round. Over to you, ma'am.
Thank you, Asha, ma'am. Good evening, Patel, sir.
Yes,
we
welcome.
learn from others. We learn from mistakes. Wherever there is a conference, we have a panel by sir, which is almost attended by everyone. We want to learn from the mistakes committed by the obstetricians. So here we have a case who during her antenatal period, she had tachycardia and breathlessness, which was treated by the obstetrician herself. And after that, she had an uneventful delivery. And on the postnatal 4th day, she died due to cardiomyopathy. So the obstetrician herself probably treated the patient and cardiomyopathy was not noticed.
Yes. So again, same answer. There should be multi-speciality approach. Because in this type of condition, whenever you see persistent tachycardia and complain of breathlessness, you cannot afford not to involve physician or cardiologist in this type of situation. So naturally, you should involve physician or cardiologist or any other specialist in this type of situation. Because if at all patient died due to cardiomyopathy, and if you are not involved cardiologist in this situation, you cannot be pardoned in court of law. Because persistent tachycardia and breathlessness, and you have not referred patient to cardiologist or physician, it cannot be pardoned.
Supposing she did not have such symptoms also, should we get a cardiologist opinion routinely?
No, on auscultation, if we feel that there is some abnormal heart sound, or if we feel there is a symptom or sign related to cardiomyopathy, naturally we should investigate, but we should refer patient for cardiologist opinion also, because in this type of situation it shows our consent that we taking care for patient. So it shows our consent if we involve any other multi-speciality approach wise, any other consultant. So, and responsibility is shared. Once we refer patient to cardiologist in this situation, whenever we have a little doubt, then it shares our responsibility.
Thank you, sir. Thank you.
Yes.
Thank you, sir. Now we have Mahalakshmi ma'am, who's the president of Madurai Society, and she actually loves traveling and making time with friends. So everywhere she is with friends. She is the president of Madurai Society, professor at Madurai Medical College, and has organized many conferences. Over to you, ma'am. Mahalakshmi ma'am.
Is she there?
She was
or
here.
anybody from Madurai can take if she is not there.
So it's Dr. Padma here.
Yes, Padma can take.
Yeah. So it's a pleasure attending your panel discussions, and there's a lot of learning value. And I've known you and Asha for quite some time, and I'm really happy that I'm part of this panel today.
Yes, welcome.
And yeah, sir. So coming to the question, there is an antenatal patient, and it was her antenatal visits were quite uneventful. She had an uneventful cesarean section also. But on the 8th post-op day in the ICU, she was diagnosed to have a tight mitral stenosis. And where should we manage such a high-risk case?
So in this case also, antenatal visits were uneventful. Patient had no complaint, and lower segment cesarean section was also went uneventful. But on 8th post-operative day, patient had a sudden breathlessness. Patient had been in ICU and diagnosed as a tight mitral stenosis. So just I mentioned prior also, if we have a habit to put stethoscope on chest of each and every patient, obstetric or gynec, then we can cannot miss this type of tight mitral stenosis. Naturally, it will be having abnormal heart sound. And in this situation, if we can refer patient to cardiologist and if care is taken, then it is good defense in our favor. Because many times, of course, it was uneventful throughout antenatal period. So it could be compensated cardiac activity. But stress of labor or stage of cesarean section could have led to non-compensated cardiac activity. And ultimately, she ended into this problem, and ultimately she died due to tight mitral stenosis. So involvement of any other specialist is the carry-home message in this situation.
So, can I ask one more doubt, sir? What is the anesthetist in this case?
Pardon?
What is the implication for the anesthetist in this case? Because it was a C-section.
When cesarean section is advised, naturally pre-operative assessment is to be done by anesthesiologist. And if anesthesiologists have also missed that she is having some abnormal heart sound or she is a case of mitral stenosis, because tight mitral stenosis usually cannot be missed. So at that point of time also you can involve a physician or a cardiologist, and we can manage patient accordingly. And after involvement of cardiologist, if result doesn't come in our favor, if at all patient goes with some complication or any bad outcome, then also it shows your concern that you have taken utmost care to save life of patient and you could be safe. Otherwise, if you have not referred patient in this situation and you have tried to treat that very patient by your own, then it becomes very difficult to face in court of law. So whenever you are having any respiratory or cardiovascular system involvement in any obstetric patient, take a reference or refer patient to physician and or cardiologist, whichever the situation, because it will be good in your defense.
Thank you,
Thank
sir.
you, sir.
So this is Dr. Padma's painting, see, sketches.
Very good.
Over
Thank
to you.
you.
She's also the secretary of Madurai Society. So now this is Padma's question.
So this is another patient who is terminally ill and she's on the ventilator, and she's on a vasopressor support also. And the relatives claim that they cannot afford any more paying for the treatment, and the intensivist also says the situation is hopeless. But then how to manage hereafter?
So this is a very typical situation. And as far as euthanasia is concerned, passive euthanasia is still not legal in India. Till now, there is only one exceptional case, Anura Sandbag case. In that very case, Supreme Court has given permission to go with passive euthanasia in that very patient. Otherwise, it is not allowed. So, in this type of situation, you cannot write in your case paper, do not resuscitate, because it becomes very difficult for us to face in court of law if at all relative goes hostile, because many times relative will tell like this, that we cannot afford much, and intensive is also case that now it is a hopeless case. But in this situation also, even if you stop all life supporting system, then also you cannot mention in case paper that please do not resuscitate. So we should be very careful in this type of condition.
Thank you, sir.
Yes.
Thank you, sir. Now we have Dr. Chandrakala Maran, ma'am. She is HOD Obstetrics Gynae, PG Medical Institute, Coimbatore. Ma'am, requesting you to please unmute yourself and put on your video. She likes historical reading. She does a lot of reading and she likes historical reading. Over to you, ma'am.
Yes. Yes, madam. Chandrakala, madam.
Yes, sir. Yes, sir. Sir, yeah, good evening, sir. Yeah. And my question is, there's a story of a young gynecologist. She's got a patient post-cesarean section with sudden breathlessness. And the question, the thing is, diagnosis is query amniotic fluid embolism. She's been shifted to a tertiary care hospital. There, the patient died after 4 hours. Now, the relatives made a police case and threatened that they will put the case in the consumer forum for 1 crore. If the case against me and the court awards 1 crore, then from where will we recover the amount, sir?
So here comes importance of indemnity scheme, because in this era of CPA, when this much huge amount are awarded in litigations cases, then we should be covered with sufficient indemnity. So I would like to mention something related to indemnity cover also. We, Foxy, have our own indemnity scheme, and Foxy had a tie-up with ICICI Lombard, and whosoever the members of that scheme, ICICI Lombard is taking care through third party, that is CoverU. CoverU is third party. So whenever any member has any litigation, any notice in this type of situation, then they will give a list of advocate in that very area where that doctor practices. And from that list, he is free to choose any advocate, and then that very advocate will assist in that legal proceeding further. And all the payment will be done by this scheme to that very advocate. And if at all case is lost, then compensation to be paid will be paid by this scheme only. There are two good points as far as this indemnity scheme is concerned, as far as your Foxy scheme is concerned. Usually in any other indemnity covered by other insurance company, they do not entertain the vicarious liability on part of your untrained staff. Say, for example, there is some mistake on part of untrained staff, then this company will not entertain you. But in Proxy indemnity scheme, there is a provision that even if your untrained staff is also covered under this indemnity coverage. One more part, outside court settlement. Many a times we have a case short to lose in court of law. So in this type of situation, in other company, there is no provision of outside court settlement, but in Proxy indemnity cover, there is a provision of outside court settlement also. So before case or during ongoing case, you can compromise with patient, and whatever amount is decided under mutual understanding, that amount will be paid by insurance scheme, that is our indemnity scheme. So these 2 points are good in favor of indemnity coverage by Proxy. But without indemnity cover, now in era of CPA, one cannot practice. And one more important thing, if you are dealing with a high risk pregnancy cases, then amount of indemnity cover should be at least 2 crores. Because in so many cases, 70-80 lakhs or 1 crore compensation is awarded in favor of patient party. So we should be very careful. And as far as this Proxy indemnity cover is concerned, premium is not that much. So Proxy cover 1 crore, 2 crore, whichever amount you are comfortable, you can choose that very segment, and accordingly you have to pay a premium.
Thank you, sir. Thanks for the opportunity, sir.
Yes, next.
Next, we have Dr. Sujata, who is the secretary of Krishnagiri Society. She loves gardening. You can see her background.
Yes.
And over to you, ma'am. She is from Annamalai University. Over to you,
Sujata, madam, welcome.
Yes, sir. Good evening, sir.
Yes. Yes. What is your question?
Yes, and I want to discuss about transfer of patients. First of all, let me thank Dr. MC Patel and Dr. for involving us in this webinar. We are overwhelmed and really enjoyed this CME. About the transfer of the patient. Am I audible, sir?
Oh, yes, you are audible. Carry on.
Sir. When regarding the transfer of regarding the transfer of the patients, and who will decide where the patient is to be transferred? Because in a multi-specialty hospital, we have a hospital owner will be somebody, and I'll be the treating doctor. And in such situations, who will decide when?
In this situation, you can advise them all the options available nearby. But ultimate decision is on part of patient and patient party. Because if they are interested to go to government hospital or trust hospital or private hospital or medical college hospital, they are free to decide. But you can guide them which hospital is nearby, which hospital is based in this given situation for them. And after all this discussion, if they decide to go to particular hospital, then they can go to that hospital also.
Yes. Next. Okay, sir. Then would you like to confirm with proper person where the patient has to be transferred?
This is also very important thing. Say, for example, if ventilatory support is required, patient reaches that very hospital where you have referred the patient and ventilator is not available. Then patient will have to be shifted to another center and precious time is wasted. So you should confirm about availability of bed, availability of OT, availability of blood, availability of ventilator. So it shows your consent also to save life of patient, and it will be beneficial to the patient. So it is always advisable to confirm all this with proper person where you are referring the patient.
And about during the transfer, about escorting the patient.
Yes. So by law, and even in all the cases, court also expect from us to escort patient in the same ambulance. with all emergency drugs, oxygen cylinder, IV line on, etc. But in the same ambulance, I mean it, because in one of the cases which happened in city of Pune, doctor was escorting the patient, but doctor was in his own car and patient was in ambulance. Patient suffered heart attack on the way to transfer and patient couldn't be revived. So case was filed and case was decided against doctor that he escorted patient, but he was not in the same ambulance and he couldn't manage patient well in time. So in this situation, whenever we escort any patient, we should be in the same ambulance. One thing. If treating doctor is busy with some emergency, then equally competent person can escort the patient. And in this situation, anesthesiologist is the best person to escort the patient. So whenever you escort patient, it shows your concern. Yes.
Yes, sir. Then about the transfer documents,
yes,
when we are shipping the patient.
Very important question. So whatever treatment we have given to that very patient at our place, we should give brief summary of that and all the investigation or any document which could be useful to that hospital where we are referring the patient, we should hand it over to the patient, patient and patient party. And it should be acknowledged. Okay, one copy should be with us also, and one copy is to be given to the patient party, and it should be acknowledged. It is very important thing. But which kind of document you have to give? So you have to simply visit Foxy website. On Foxy website, Foxy Uniform Consent.
Excuse me, sir. That is the next question. So that is the next question.
Okay.
So thank you, sir. Thank you, Sujata ma'am.
Yes,
Sorry
ma'am.
for
Thank you.
interrupting you, but we have Professor Dr. Dilshad ma'am, who's the former director of ISO KGH Madras Medical College, and her hobbies are reading and actually spending time with children. Over to you, Dilshad ma'am.
Good evening,
Please put
madam.
on your video.
Yes. Welcome.
So thank you so much. At the outset, I thank Patel sir and madam for giving me this opportunity. That my question is, what is the importance of consent and what are the records to be kept in high risk pregnancy?
So as far as consent is concerned, consent is very much needed in any of patient where we are treating any of patient in any given situation. But when we are dealing with high risk pregnancy cases, then special consent should be taken related to high risk pregnancy case. And for that, just I was mentioning, it is available on Foxy website with title Foxy Uniform Consent. With three medical legal experts, Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad, we have prepared 30 different consents. Say, for example, cesarean section. Say, for example, hysterectomy, abdominal, vaginal, endoscopy, blood transfusion, medical termination of pregnancy, medical method, surgical method. In those very consent for anesthesia, consent for blood transfusion, we have prepared consent or a list of transfer document at the time of transferring patient to higher center. So in that very consent, it is available. So you can download those consent and you can use in your day-to-day practice. We have prepared all those consent taking base of famous case of Samira Kohli versus Prabha Manchanda, which was decided in 2008 in Supreme Court. And Supreme Court has very specifically mentioned what is the ideal consent in Indian Constitution. And in that very case, whichever points Supreme Court has advised or mentioned, we have taken care at the time of preparing this consent. So we have prepared all those consent in two parts. Part one is information and part two is undertaking. In information, there are some 8 subheads. So in that very, say for example, name of procedure or name of surgery, cesarean section. Meaning. So what is the meaning of cesarean section? We have prepared in a very simple language. Say for example, to cut open abdomen, to cut open uterus and to deliver baby. That way we have prepared. So name, meaning, indication, why this surgery is offered to the patient. Then consequences of refusal, if patient is not ready to give consent, that which are the consequences of refusal of consent. Alternatives, which are the alternatives to the treatment, whichever option you are offering, are other options are there as far as treatment protocol is concerned. So that way, and all the substantial risk or probable complication related to that very procedure, we have mentioned that also. Say, for example, possibility of infection, complication of anesthesia, outcome of baby, possibility of hemorrhage, possibility of trauma to nearby structure during surgery. Say, for example, if we are dealing with a case of severe endometriosis, it is all likely that it may end up into trauma to ureter, trauma to bladder, to bowel. So we have mentioned all this in this consent. And part 2 is undertaking. So whatever we have mentioned in part 1, patient will go with undertaking that I had explained whichever written in part 1, and I had been answered all my questions, and after this I have signed the document. So this is very important as far as consent part is concerned.
So the next question is, against whom and where can complaint be lodged? Sir, am I audible?
Oh yes, you are audible. So as such, any service provider, patient or patient party are free to make party to anybody, gynecologist, anesthesiologist, pharmacist, infrastructure staff, or radiologist, that is sonologist. So patient is free to file complaint against anybody. So in short, we can say any medical service provider could be victim.
So what can be done to protect ourselves, because we are living in this era?
Yes. So in this era of CPA, we have very clear recommendation. So 3 words very important. So court also expect from us. Then that is one is anticipation or foreseeability. Because in any given situation, whenever you are facing litigation, you have to answer few questions. First question is, was it preventable? Whatever happened, say for example, it was case of central placenta previa and something went wrong. So question will come, was it preventable? So you cannot say no usually. So if it was preventable, then what did you do to prevent it? And in spite of all your care and caution, if you couldn't prevent and some complication happened, then did you diagnose that complication well in time? And did you manage that complication way in which any prudent gynecologist would have managed? So if you can answer all those questions, then you could be out of problem as far as litigation is concerned. But for that, 3 things is expected from you by court. And one is expectation, this anticipation or foreseeability. Just I was mentioning about central placenta previa. So if it is a case of central placenta previa, naturally one should anticipate that she may end up into PPH, she may require blood, she may require obstetric hysterectomy also. So if we have anticipated and if we are readily available to deal with the situation, then it shows our consent and we are out of problem. So for that, second part is proper communication and counseling. Because in one of the famous case of C. Jaipal Reddy versus Padmini Veluri, in that very case, National Commission has very specifically mentioned that consent paper is not mere piece of paper where patient or patient party has to sign, but it is a very important document of your communication, important document of your counseling. Whatever you have counseled, whatever you have communicated to the patient, all the point discussed should be entered in that very consent paper, and then after patient has to sign or relative has to sign as a witness. So if you have mentioned each and everything in consent paper, then it becomes a good defense. And one more area is record. Whatever you have done in good faith of patient, it should be well recorded, and whenever asked by the court, it should be offered in the court. So foreseeability, proper counseling and consent, and proper documentation will be at your rescue. So you could be saved if you take care of all this.
Thank you, sir.
Yes, welcome.
Now the session is open. Our respected guests of honor is still with us. Sir,
Yes.
Chakravarti sir would like to say something.
Yes, yes, welcome,
Yes,
sir.
sir. Very nice, sir. I am very pleasant here. my simple suggestion, add one more line to your word is,
yes,
the obstetricians should have a holistic team with them, physician, surgeon, because some of the people in antenatal come with pain abdomen, maybe appendicitis or cholecystitis. So you have a holistic approach and have a close friends with others so that we can help each other, and end result is we give a good care to the patient. Sir, very nice, sir. Thank you for honoring me, and thank you very much for the discussion, sir. Thank you.
So very,
Good night,
very
sir.
good and important comments by you, sir, because many times very nicely mentioned by you. Pain in abdomen doesn't matter. It could be obstetric.
Yes,
There
sir.
could be some non-obstetric region also.
Yes,
So
sir.
if we involve surgeon in this situation, it shows our consent to take care of patient, and we are saving product.
I had 2 or 3 cases, sir, but it's perforated. So we had to go like that. Thank you, sir. Thank you, sir.
Yes.
Good night, sir.
Sir, Amla Devi ma'am is also present. Amla
Yes,
Devi,
madam.
would
Amla
you
Devi,
like to
madam.
add something?
Yes,
I
our expert comment.
Whether to suppose if the wife comes, we are getting consent from the husband. Is it necessary to get from the in-laws also? Because sometimes the parents are telling one thing and the in-laws are making trouble, no? After any surgery or anything goes wrong, in-laws also, whether it is necessary to inform all the family members when something untoward happens.
So as far as consent is concerned, if patient is major, if patient is mentally sound, only patient can give consent. All the other signature are witnesses. Witnesses means she had been explained before us about this surgery or procedure, and she had signed. So role of witness is only this. Whichever matter we have mentioned in our consent paper, witnesses had nothing to do with that matter. So in this situation, it is very clear. But in case of death, many times we have to face this situation in a very awkward position. If patient is dead, and only in-laws relative are with patient. So in this situation, it is always advisable to inform our parents' part also. And if we advise post-mortem examination, many times in-laws will not be interested to go for post-mortem examination, and parents' part will be interested to go for post-mortem examination. So this is a very tricky situation. But in this situation, we have to simply inform police, and police will take charge of body, and he will submit that dead body to post-mortem examination. And when marriage life is less than 7 years, it is very important situation in eye of law also. When marriage life is less than 7 years, whenever there is sudden death, you always inform police and you always insist for post-mortem examination. Because in this situation, there will be panel PM. So 2 doctors will do a post-mortem examination when patient is having less than 7 years of married life.
Okay, sir. Thank you, sir. Thank you so much for including us also from the extreme south of India. Then we are always honored to be.
Thank you, madam. Obliged.
Okay,
So one
sir.
question, sir.
Yes, welcome.
Sir, when do you think it will be appropriate to do an echo for the pregnant patient?
Pardon?
Echocardiogram.
Echocardiogram. We have to refer in this type of situation either to physician or cardiologist, and then cardiologist will decide whether echocardiography is needed or not, because we are not master of that very subject, and law doesn't expect from us also. Law expects from us only obstetric and gynec related situations. In any other situation, if we refer patient to that very speciality, they will advise about it.
Thank you, sir.
But in South India
One
nowadays,
minute, Dr. MCB, in our Tamil Nadu, echocardiography is done routinely to all the antenatal mothers. ECG
It's
also
fine.
we are doing routinely.
It shows your abundant caution, I would say.
Yeah.
In eye of law, it is abundant caution. But even if in all routine cases, if it is not advised as far as echocardiography is concerned.
Actually, the government has put a guideline.
Government
All
is
pregnant
giving
women should
guidelines.
undergo
If
echo.
it is protocol or circular on part of government that
Yeah.
all patients should be subjected for echocardiography, then naturally it should be.
Sir, one more question, sir, regarding teenage pregnancy less than 18 years. When they come for delivery, she's a booked case and she's coming to us for delivery. Who is supposed to have informed the police? Those who have booked or those who's conducting the delivery? When she's coming for to us?
I would say any person who comes to know that she is less than 18 and she is pregnant is under obligation to inform police. So in government hospitals, say for example, in your unit, your first year resident saw the patient first and she is pregnant, she is less than 18. In this situation, resident should be explained that in this situation, you will inform your teacher, your professor, head of the unit. And head of the unit is under obligation to inform police.
Suppose she is booked in another place and she is coming to us for delivery or for ultrasound she is coming. Can we do an ultrasound in our center? Or should we inform the police again?
Yes. Once we have come to know that she is pregnant and she is minor, we have to inform. Irrespective whether she had been to another place, she was advised, not advised, we are less concerned because we never know that fellow who had examined or treated that very patient has informed police or not. And I would like to mention very quickly one case which happened in city of Mumbai only. Patient had a complaint of pain in abdomen. Mother took her directly to sonologist and sonologist had a sonography and it came out to be a case of 16 weeks pregnancy. So mother took that baby to gynecologist. Gynecologist informed police. Police went to sonologist. Why you didn't inform? Once you came to know that patient is pregnant, patient is minor, it becomes a case of POXO and you are under obligation to inform police. So irrespective whether she has taken treatment anywhere else, whether they have informed, once patient comes to us and we come to know that she is pregnant, she is minor, we have to inform.
Thank you, sir.
We have to end in 2 minutes.
Yes,
so if
yes.
you would just let us make the appeal and then we can go on.
So at the end, I would like to request all the delegates and all the guests who have attended this webinar to endorse my candidature for post of President Foxy, election year 2024. From 1st to 10 August would be election, and consider my seniority, sincerity, dedicated work in Foxy for years together, and readily and easily availability to any Foxian friends in any given odd situation. So please endorse my candidature and please support me in my election. And same way, Dr. Asha Jain is also going to contest for chairperson, Food, Drugs and Medical Surgical Equipment Committee, Foxy. So I appeal on behalf of Asha to endorse her candidature also. In month of May, there will be letter from Foxy to each and every society president secretary to send nomination. So in month of May, you will send nomination for me for post of president, for Dr. Asha, chairperson, Foods, Drugs and Medical Surgical Equipment Committee. In month of August, 1 to 10, you will have to vote for me, and from 15 to 25 for Dr. Asha Jain. And Asha Rao is also contesting. So you will have to nominate her also, and you will have to vote for her also. But her voting will be with me only from 1st to 10 August.
Thank you very much, sir. Asha Rao here for your kind
if you have
wishes.
to appeal personally, you are
I know. But more than anything, we have seen your hard work for last so many years. So it will be very nice to see you see your success. And Asha Jain also is a very sincere, hardworking person. I wish her also the best. I wish both of you the very best. I told Asha in the very morning.
Best of luck to you also.
Yes, and I should be contesting for the post of Vice President South Zone. So all of you kindly nominate me and then support me.
Yes, yes.
Thank you so much.
Thank you. Thank you. Shubharatri.
So thank you all, and thank you, Corona people also, Nilesh and Tirth both. Thank you very much.
Thank you so much,
Thank
sir.
you, sir.
Thank you.
Thank you and good evening all.
I'm ending the session.
Oh,
Yes.
yes.